Good morning, everybody. Welcome. Depending on where you are in Canada or throughout the world, good morning or good afternoon to you all. And thank you for joining us today for our conference, Moving Cases Forward, a Solutions-Based Approach. My name is Maria Miliotto, and I'm Vice President here at National Programs here at Lifemark, representing our wonderful company. We have over 330 participants who signed up from all across Canada, all 10 provinces, even a number of participants from the US and the UK. You participants represent all of the key funders and stakeholders, WCB, MVA, LTD, employers, healthcare practitioners. We work with on a regular basis. So we wanted to take this opportunity to get in front of all of you and share relevant subject matter that is timely, evidence-based, and easy to apply in your everyday work. A special thank you to our expert panel of speakers today and our conference team that helped us accomplish this task. The subjects covered today are some of our most challenging types of cases we deal with, and I hope you find the suggestions and ideas offered will be of benefit to you. This conference accomplishes many of the core values we hold dear here at Lifemark, including going the extra kilometer, doing the right thing, having fun. So please sit back, enjoy the conference, and from all of us here at Lifemark, welcome. Enjoy the conference. These are great speakers. We have an awesome team, and I'm really proud to be here. So I'm going to now send it to Julia. Julia, it's all yours.
Thank you, Maria. Hi, my name is Julia Reed, and I'm the Director of Occupational Health and Wellness for Canada. I'll be your host, as Maria mentioned, for today's session. I'm going to be assisted by a number of our great committee members who've helped organize this conference. And on behalf of the Lifemark Health Group, we're so glad you could join us and be part of our 6th virtual conference that we've been able to offer over the last 3 years, Moving Cases Forward, a Solutions-Based Approach. As Maria mentioned, we have a number of participants registered. We are recording today's conference, and we'll be sending out a link following in case you want to re-listen to a speaker, or you maybe want to share it with a colleague or one of your teams. Before we would start, we have a wonderful panel today who has come together to provide a bunch of information based on previous surveys that we've received, individuals looking for certain topics and information in regards to the speakers that we have today. So we're very thankful to have this expert panel to present this information and to meet that need based on previous sessions. Today's sessions all have a very common thread, handling complex cases. This conference is really meant to continue to help add some additional tools to your toolbox to managing these difficult cases. As we know, they come up and no two are ever the same. And how we approach them, there's always the basic fundamentals, but there's always different ways to think outside of the box about how can we move this one forward. And today's sessions will provide you with some of those additional tools or things to try that maybe you haven't tried in the past. The form of our session today is to have each speaker speak for about 25 minutes or so, and it will be followed by a 5 to 10 minute question and answer session. So if you have any questions for our speakers, feel free to pop them into the Teams Q&A, and the moderator will raise them during our Q&A time. So JC today will be our moderator. She'll be raising your questions and grouping them into themes as they come in. For those of you who've been with us before, we've used the chat for questions, but we have disabled it this time for this conference. What we do have is the Q&A. So right next to the chat at the top of your screen, you'll see a box with Q&A. If you can please click on that and then type in your question, and JC will be monitoring that throughout the presentation. Unfortunately, with a group of this size, we ask that you please turn your cameras off and that you do place your Q&A in the Q&A section, just because it's just better for the connection and helps make things go smoother. After the second presentation, we will have a short 5-minute break so you can refresh your coffee, stretch your legs, take a micro break, and then we'll return for our final presentation and Q&A session as well as closing remarks. Following the session, we will send out that link to you of the presentations along with a post-event survey. So we're really excited to learn about what types of topics you'd like to see us cover. We really want to make these conferences very applicable to the information that you're looking for that can help you in terms of your jobs. And we will be starting our planning of our April 2024 conference. So if you can take a few minutes when you receive that link to let us know. As well, if you do require a certificate for today's session, we'll have information on how you can reach out to get a certificate as well. At this point, I'd just like to introduce Corinne. She's our clinic director with Universal to introduce our first speaker. Thanks, Corinne.
Thank you, Julia. Good morning, good afternoon, everybody. So I'll introduce this morning our first presenter. So Ravneet is a primary healthcare nurse practitioner with over 10 years experience in the nursing field. She completed her Bachelor of Science in Nursing at York University and then earned her Master of Science degree at University of Toronto. Her nursing career began in obstetrics, and although being involved in the birthing experience was very rewarding, she yearned for more learning opportunities and expanded her scope into critical care nursing and worked in a fast-paced acute care environment. Having worked in 2 different specialties, she had enhanced her practice and education to caring for clients from many different age groups and spectrums in their lives. This ultimately guided her to primary healthcare and the role of a nurse practitioner, a role she has been prancing in for the past 4 years. As a nurse practitioner, her experience varies from primary care to specialties in cardiology, travel medicine, and clinical research health policy development. It is my pleasure to present Ravneet Dhillon. Ravneet, take it away.
Hi, good morning, everyone. Thank you for the introduction. So I'm just gonna put up my presentation here. Just want to confirm everyone can see the slides and hear me.
Yes, we can see and hear you.
Perfect. Okay, so my name is Ravneet Dhillon. I am a primary care nurse practitioner, and today my topic of discussion is going to be the nurse practitioner and our role and how we are partners in health. Okay. So our agenda for today, I will talk about in just an introduction into a nurse practitioner's role, our career, the age-old question, which is what is the difference between physicians and nurse practitioners, and what is in and out of the nurse practitioner scope of practice on a national viewpoint, so across the province and territories, and the nurse practitioner assessment pathway, and then nurse practitioners as essential contributors to comprehensive management plans as well. So let's begin with an introduction to nurse practitioners. So historically, the role came about to be in rural and remote areas of Canada that didn't have access to healthcare or family physicians. And although the nurse practitioner role was introduced in 1967, so quite a bit ago, the role didn't gain momentum until the 1990s when there was a call to expand the scope for better utilization. And currently, there continues to be changes in legislation to continue to support the expansion in our scope of practice. So the nurse practitioner, or NP, or also known as an RNEC, which is a registered nurse with extended care, is an advanced practice registered nurse who has done additional education, acquired the expert knowledge base, complex decision-making skills, and the clinical competence for expanded practice. The qualifications for a role typically start with completing a Bachelor of Science in Nursing degree, followed by 2 years or a minimum of 2 years as a practicing registered nurse. After that point, you can now apply for your Master's of Nursing after those 2 years of experience is completed. And you would do your nurse practitioner degree at the same time as your master's. You can do it separately as well, or you can do it together. So with the interest in nurse practitioner role increasing, more education programs are arising, and nurse practitioners on average typically have more than 8+ years of academic and clinical preparations for the role. Unfortunately, most of Canadian population still does not know what nurse practitioners do, but they are a great resource for Canadians that require a provider. So in the current climate, we continue to have significant issues around access to primary care, and nurse practitioners are very much fitted to address that role. So there are 3 different types of nurse practitioners. We have primary care, which is the field I am in, acute care, and pediatric. With acute care, the main focus is adults and geriatrics. With pediatrics, of course, it's mainly children. And for primary care, we do the whole scope from pediatrics all the way to geriatrics. So you'll notice more acute care is in, and pediatric care typically more in hospitals in those specific specialties. And primary care, you'll see more so in the community, which we'll talk about where we can find them as well. So what is the difference between a physician and a nurse practitioner? So nurse practitioners are the only other healthcare provider currently, along with family physicians, with the experience, skills, and training, and the legislated authority to provide a full complement of primary care services. Nurse practitioners typically use their foundation of nursing from their previous experiences and education in their approach to patient care. Physicians typically take medicine in a medical degree, and nurse practitioners learn the foundation of how medicine applies to the practice of healthcare. So with physicians, the focus is more on a biomedical model, whereas nurse practitioners are able to incorporate the biomedical model plus the holistic care approach from their nursing background, to both of which are valuable but different approaches from their schooling. So the provider difference does aim at illness care versus wellness promotion. So this involves more education around better health habits before the illness takes over. So the focus is on how to keep the patient well using the wellness model versus a focus on just illness care, which is more of the medicine model. And although nurse practitioners share some of the same knowledge and expertise as physicians, and they do have overlapping scopes of practice, nurse practitioners are not assistants to physicians, or nor are they meant to replace physicians. It's all about being an adjunct to the system and being able to roster our own patients, have our own practice, but when an issue arises outside of our scope of practice, then we would refer out to physicians or specialists if that is the case. And another difference between them is that physicians typically have a more fee-for-service position, whereas nurse practitioners typically are salaried or hourly. So why that makes a difference in the care provided is the fee-for-service system drives more volume. And with the nurse practitioner, with negotiation, we have more time for patients. So typically, instead of a 5 to 15-minute appointment, we get the 20 to 45 minutes that allows us to get to know our patients better, develop a deeper relationship, and know what their needs are and provide health education because we have the time to incorporate and apply our holistic care. And most Canadians are still familiar with physicians as this was the main role for provider in the past. But now that we have nurse practitioners, Canadians are unaware that nurse practitioners are also providers, primary care providers, and they do provide a similar quality of care as their physician counterparts. So we'll talk about the scope of the nurse practitioner. So with our education and experience, we are able to do the following services for Canadian patients. This includes being able to autonomously diagnose and treat illnesses, order and interpret diagnostic testing, prescribe medication and formulate treatment plans, and perform medical procedures and provide referrals. So across, nurse practitioners can provide care across a lifespan. So this means from preventative care, prenatal care, mental health care, episodic and chronic illness care, palliative care, and medical assistance in dying. We are suited to practice in all these specialties. And the role also includes research and education. So this allows us to be consulted by multidisciplinary teams. This includes physicians and members to incorporate the new knowledge into practice. So nurse practitioners are bringing value to the Canadian healthcare system by improving timely access to primary healthcare and reducing that pressure on the healthcare system. So this is just a chart I created to try to summarize in terms of scope of practice, full and restricted across all the provinces and territories in Canada. I'll get into what they specifically mean. So I just want to make sure, just want you to know that each province does already have a regulatory body that is responsible for setting these entry to practice competencies, the standards of practice, and the requirement for licensure for nurse practitioners. And based off of those is where we stand with our scope of practice in the different province and territories. So there are 4 main categories for scope of practice. So the first one is independent therapeutic management. Second one is pharmacotherapy. Third one is treatment and advanced interventions. And the last one is other advanced scope activities. So for the independent therapeutic management, this is the one that I took kind of similar to what I just spoke about earlier. It's the ability to conduct advanced health assessments and diagnoses, order and interpret diagnostic tests, consult with and refer to other healthcare professionals, and then roster and manage patients. So when I talk about restrictions and what is full scope, so for example, in Alberta, we're able to do the full scope of practice for all those categories that I listed. In Ontario, there is a restriction. The restrictions are typically in terms of diagnostics. So nurse practitioners are still not able to order nuclear medicine testing, like ionizing radiation in nuclear medicine, radiation therapy. These are things that still require physician collaboration, and it's not something that we could do autonomously. But however, as of July 2022, so just last year, we were given the ability to autonomously prescribe or order, CT and MRIs. So that is a big help in terms of our scope and expanding our scope. Another restriction in this category is being able to roster and manage patients. So certain provinces, they still cannot roster and manage patients on their own. However, this is changing. In most provinces, nurse practitioners are rostering patients on their own. Ontario is a bit restricted, but they recently changed legislation for that as well. And nurse practitioners, they have nurse practitioner-led clinics, and we're able to roster our own patients. And other provinces, I believe in Quebec, we still can't, but it's something that is growing and expanding in our role. And given our primary healthcare crisis currently, this is something that we're expecting to expand and get full scope of practice in. The next category is pharmacotherapy. So this includes prescribing pharmacotherapy, prescribing controlled substances. So it is, for the most part, full across most of the country. In Quebec, New Brunswick, Alberta, British Columbia, there is some restrictions. The restrictions are specific to that we cannot prescribe opium, coca leaves, anabolic steroids, except for testosterone. And another thing is in 2018 is when they officially added the controlled substances prescribing scope for nurse practitioners. So some nurse practitioners that were licensed prior to that, they would have had to do an additional course in order to get those prescription of controlled substances within their scope of practice. So there is additional education, but anybody else that has been coming out of the nurse practitioner program 2018 and afterwards, it's part of the program now. For treatments and advanced interventions, we're talking about prescribing medical supplies. So, and this is typically with any type of treatment or intervention. The restriction is more so involving more high-risk treatments such as surgeries, things like that. This is still not within the nurse practitioner's scope of practice on a autonomous level. This is something that still requires physician collaboration. And the last one is other advanced scope activities. So this one is including having full hospital privileges, admitting to long-term care facilities, completing Form 1 for involuntary hospital admissions. And typically for this, it's out of scope or restricted in most cases, just because in terms of hospital patients, acute patients, we do still require physician collaboration, as usually most of these patients in these settings are being followed by a physician as well, and we're usually in collaboration with that physician. So the restriction and out of scope comes from the fact that it's not something we can do autonomously. And again, if anything that is not within the scope of the nurse practitioner, or if the nurse practitioner personally does not feel comfortable within a certain care plan or diagnosis or whatever situation, they can always collaborate with physicians, whether that is a physician that you're going to collaborate with in person, if you're working with them at a clinic, or even from a distance. So we can still collaborate with physicians from a distance, create a plan, and then as a nurse practitioner, we can then independently implement that plan and those orders. The nurse practitioner pathway, so assessment pathway. So nurse practitioners are healthcare professionals that have been well versed in bringing medical knowledge along with the core values and skills of nursing to provide a healthcare approach to treat the person as a whole. And in order to do this, we start with gathering comprehensive medical histories, addressing a person's physical and mental health, providing health coaching and offering ways to lead a healthy lifestyle, and of course, individualizing education and the management of chronic illnesses. This includes incorporating their cultural and spiritual health, especially for First Nation populations. So how NPs can move cases forward. So an example in occupational health. So nurse practitioners are able to complete independent medical examinations, return to work forms, and we can assess patients based on their diagnosis of injury, reassess, and lift or modify restrictions as needed in a timely manner. So we can also manage, there is management of minor workplace injury. So if a patient or a client gets injured at the workplace, instead of them having to wait to see their family doctor or being sent to an emergency, if it's a minor injury that can be handled, a nurse practitioner can help manage that injury, whether it's in office or if it's somewhere close by or having a referral clinic that you go to. If it's anything more serious, nurse practitioners can always stabilize a more serious injury and arrange for higher level of care if needed as well. And of course, we can always reestablish health promotion through education and programs throughout companies as well. Other things that nurse practitioners are able to do in terms of moving cases forward is performing driver's medical reports, assessments, driver's medical exams, ordering diagnostics and management in a timely manner for workplace injuries, such as x-rays or ultrasounds if the patient needs it, instead of waiting a couple weeks or days for them to be seen by a family practitioner. If they're not available, then they can see a nurse practitioner to get things moving a little bit quicker, so that the management starts quicker, diagnostics start quicker, and hopefully recovery and forms and everything is arranged in a quicker and timely manner. And we'll talk about a case study at the end regarding that as well. So nurse practitioners as essential contributors in comprehensive management plans. So these are a couple of things that nurse practitioners can do from a research, policy, programs side. So we can develop disease prevention programs such as smoking cessation, exercise, healthy eating programs, serving as gatekeepers for healthcare service, including rehabilitation, disability matters, counseling employees on physical and mental health issues, and guiding them towards the appropriate community resources and/or employee assistance programs if needed. And then conducting research on the effects of hazardous work conditions, workplace exposures, which may include gathering data and then reporting the findings to the employer. So all of this, we're able to develop and implement health and safety programs for companies and document all employee injuries and illnesses within the workplace. So I know for me, I also was a part of the Joint Health and Safety Committee previously in my research facility. And this is something where they did not have a program before, and the nurse practitioners collectively were able to create these healthy programs, Joint Health and Safety Committee programs, what to do if, for example, a needle stick injury were to occur, if any injuries on site were to occur, how we would handle each situation. And it's not just good for us as healthcare practitioners and nurse practitioners to know, but it's good for employees to also know what is the risks, and if you were to get injured, what would your steps be, instead of kind of having that panic or fear of we don't know what to do next. It's just giving healthcare confidence to the environment as well. You can also observe and assess the work environment for potential hazards and dangers, and then oversee and implement emergency and disaster preparedness programs and plannings as well. So nurse practitioners do still remain an untapped resource, and there's so many stats to show that nurse practitioners are helping our healthcare system, and these are just a couple that I wanted to share. So there has been a 20% reduction in emergency room admission from long-term care with nurse practitioners. There's been a 24% increase in family satisfaction with quality of care, a 55% reduction in the use of multiple medications, because again, we have the time to be able to do medication reconciliations with patients. Every province and territory does already have nurse practitioner legislation in place, so it's easy to try to implement them into your workplace or in your community as well. With 58% of the nurse practitioners currently more so working in hospitals, 15% are in community, 15% in long-term cares, and 10% are within other business or telehealth programs. So nurse practitioners are up and coming. They're becoming dominant in the provider field and are a breakthrough for healthcare in the provider section. And they're helping reduce the burden on physicians as well. And a couple of benefits that are leading to these statistics are that there are decreased appointment wait times and increased same-day appointments, or you can get appointments within 33 days for urgent patients. The care is also cost-effective, high-quality care, which helps improve the health outcome. And currently, there are 3 million Canadians that receive primary care in the form from an NP. And typically we do work in more remote areas, family practices, primary care networks, outpatient clinics, and usually the more acute care nurse practitioners will work in urgent care and emergency departments. As of 2022 in Alberta, there is 812 nurse practitioners, majority of which work in acute care or specialty outpatient clinics. But the number of nurse practitioners participating in primary healthcare and community settings seems to be much higher in other provinces and territories across Canada. And I do have a map that will talk about this again. And it's just something that Alberta needs to incorporate more into the primary care world. And currently, Shoppers Drug Mart is contributing in many ways across the enterprise to improve access to care for Canadians, with nurse practitioners in our virtual care program supporting patients with limited or no access to family doctors. So in our program, we've had many incidences where we have workplace clients that come in that have had an injury, and we would just move their cases forward in terms of diagnostics, treatment, starting them on a plan, and then forwarding them to if they need a family doctor. There are restrictions for virtual care in terms of return to work, but for nurse practitioners in general, in-person basis, they're able to complete all those forms for them. So nurse practitioners are one solution to a healthcare system under severe stress. So 50 years of research has shown that nurse practitioner care is equivalent to that of our physician colleagues and has equivalent or higher patient satisfaction. There are some barriers to our role, though. The barriers typically include funding for our role, which has led to a lack of opportunities and initiatives that are needed to continue to support our role. So the barriers with funding, although Ontario has been able to open more opportunities for nurse practitioners and than other provinces, currently, it is still a growing field. Currently in Ontario, they do have 25 nurse practitioner-led clinics that are able to roster their own patients, and they currently are serving 100,000 patients on their own with just a nurse practitioner lead. And in terms of timing, so health is complex. It is difficult to address a concern in 5 to 10 minutes. So such as mental health crises or financial stress, things like that. So even appointments like immunizations, which can be in and out, when you're given that extra time that a nurse practitioner has, you have time to discuss their health in general. And this is a way where we're able to promote health promotion and screenings. We're able to promote patients. Oh, you haven't had your colon cancer screening yet. You haven't had your pap test yet. This is something that we can remind them if we have the time to go through their chart to double check all these things versus being a 5-minute in and out appointment, which is typically the case when it's higher volume and fee-for-service physician roles. And given that there's such a primary care crisis and physicians are overloaded with these patients, they don't get that time. Nurse practitioners can help decrease that burden and bring it back into health promotion for these patients. And
sorry,
yeah.
Ravneet, I'm just going to give you a 2-minute warning if that's okay.
Okay, yeah, no worries. So we do need to change the nurse as a nurse mindset to give respect to the nurse practitioner role. And historically, patients still want a physician, but once access, exposure, and care is provided by a nurse practitioner, this view becomes shifted and patients continue to be satisfied with the care that they receive. And if you can't find a family doctor, you're not alone. There are almost 6 million Canadians that don't have a family doctor currently, and they're relying on emergency rooms or walk-in clinics. And this is leading to the call for expansion for the number of nurse practitioners. And this is why I believe we're going to be a great help to our primary care, our system, and our healthcare system in general. So the next slide is just a map of how many nurse practitioners we have across Canada. So the number is growing with the 8% career growth, but we are still less than 10,000 nurse practitioners across the country in comparison to our physician counterparts, where there are over 96,000. So we still have room to grow. And post-COVID, more people are talking about nurse practitioners with ERs being swamped. So there is an increased call. But the best way to do what we do is I think I shared it. Just bring it up. But the best way for us to continue to do what we're doing is to talk about our role, talk about nurse practitioners, and more role recognition is essentially access to primary care as patients learn more about them. I have 2 minutes left, so I'm just going to go through a quick case study. I'll just rush through this process a little bit. So an example is Aaron is a 35-year-old male, injures his right shoulder while at work, lifting boxes. He remains in pain, is unable to continue the full scope of his employment role, and he tries to book an appointment with his family doctor, but the family doctor is unable to see him for at least 2 weeks. His workplace is waiting on his application for short-term disability. How can the nurse practitioner help in this situation? So to be seen quicker, Aaron can go to a nurse practitioner-led clinic or a family health team. This is typically where you can find nurse practitioners, and nurse practitioners do have more availability than physicians and time for a longer appointment, which is what Aaron needs, considering he'll need a physical assessment and a form filled out, which can take up to 20 to 30 minutes. A nurse practitioner can also order an X-ray or an ultrasound to assess the injury, and that way Aaron can get diagnosed quicker. So Aaron was diagnosed with tendinitis and a partial rotator cuff tear of his right shoulder, and he was prescribed medication and referred to a physiotherapist. So we are already starting management for the injury, and we're referring out to physiotherapy to start that process as well to help with the recovery. The nurse practitioner can fill out Aaron's short-term disability form and recommend modifications based on the examination. Aaron can then continue to follow up with his nurse practitioner to reassess the injury and work close with the patient to meet these needs versus having a difficult time getting in to see their physician. With the nurse practitioner, he'll be able to follow a little bit closer and have better availability. And that way the return to work goals can be met in a timely manner, which will ultimately allow for an expedited return to work. So this is an example of how a nurse practitioner can be used to move a case forward. These are just some references, and that's it. Any questions? I hope you guys learned about our role today.
Thank you, Ravneet. That was excellent. And I certainly was able to glean a little information, especially how to differentiate between a family doctor and a nurse practitioner. We do have a couple questions. How would someone go about finding a nurse practitioner? So I think you had mentioned it briefly, but is there a specific way that someone could seek out a nurse practitioner if they wanted to?
Yeah, so depending on the province, it kind of varies. I know for Ontario, we do have Connecting Ontario, which is a government website. And off that website, it says if you want to find a doctor or find a nurse practitioner, you can actually apply to gain access to have a primary nurse practitioner as your primary care provider. Alberta, it still currently just says physician when you look to try to find a primary care provider. But if you look up nurse practitioners within the area and you're able to reach out to them, just looking at nurse practitioners accepting patients within your city, then you're able to find nurse practitioners across the provinces. But Ontario does also have nurse practitioner-led clinics and family health teams that typically incorporate them. In Alberta, if you do have any clinics, you can reach out to see. A lot of the times nurse practitioners are working with physicians as well to see if the clinic also has a nurse practitioner there and if they are accepting patients, then you can roster yourself and get access that way as well.
Perfect. Thank you. We have a couple more. Can nurse practitioners refer to a specialist consult if they feel it's necessary?
Yeah, so I do it all the time in case for if there's any concerns I think a patient may have coming with a skin condition, it may be cancer or melanoma. I'll refer to a dermatologist for a patient. Have referred to nephrologists for patients, for diabetes, endocrinologists. We can do any referrals. So it's the same scope in terms of a family physician. If there's anything that we don't feel comfortable with, or if a patient needs a referral for something, they can always come and we can send in the referral.
Perfect. Thank you. And one last question. Well, it's a two-part question. Can nurse practitioners complete the necessary provincial forms for WCB workplace injuries? And what constitutes a minor injury when you had mentioned that you can facilitate a minor injury versus a more complex injury?
Yeah, so nurse practitioners can definitely do all the forms necessary for WSIB, return to work, long-term disability, short-term disability. All of those can get done. The only restrictions is in terms of virtual care, and I know more virtual care programs are arising, is the long-term disability or short-term disability. These are forms that can't be done virtually. They have to be done in person because they typically require a physical exam portion to it. So that would be the only restriction in terms of virtual versus in person. But once in person, nurse practitioner does have that scope to complete all those forms. In terms of a minor workplace injury, so these are things like, if they had like a needle stick injury, if they had a minor cut, if, they had a burn, a mild burn. These are things that we're able to do wound care. We can do stitches. We can essentially control and manage these type of injuries. If it's like just an injury to the shoulder, providing ice, medication, prescribing medication. If somebody comes in and it looks like they had a cut at work and they come in and it's starting to look a bit infected, we can start their we can prescribe them antibiotics to their pharmacy and start treatment. And these are minor things that we can handle on our own. More severe is when it's like, okay, I got to send them to the emergency. So those things would be out of our scope. But I mean, nurse practitioners have worked in hospitals. We've worked as registered nurses, so we know how to stabilize the patient. So even if it is something like an employee, like somebody coded or somebody has a serious bleed, we can help stabilize that before we send them over to higher care.
Perfect. Thank you so much for that. And thank you for your presentation.
Yeah, no worries. Thank you.
Thank you very much, Ravneet. We really appreciate you helping us get a better understanding of the nurse practitioner role. That's something we get asked a lot about, is what can people do under their scope of practice. So I think we've all gained a better understanding today, and especially how to access nurse practitioners and the types of things you can assist with in terms of just especially that last question around completing forms, seeing people for minor injuries, etc. So thank you again for your time today. I'd like to introduce Monique, our Director of Business Development in Atlantic Canada, who will introduce our next speaker.
Good afternoon, everyone. It's a pleasure being here, and it's my pleasure to introduce Tanya Nickel, our next speaker. Tanya is a registered physiotherapist providing rehabilitation services in Lower Sackville, Nova Scotia, same province I'm in. Tanya obtained her Bachelor of Science degree in biology from the University of New Brunswick in 1999 and went on to graduate from Dalhousie University School of Physiotherapy with distinctions in 2002. She received the Award of Excellence from the Nova Scotia Physiotherapy Association in 2016. As a lifelong learner, Tanya has completed numerous postgraduate courses, including her CAFCI, acupuncture certification in 2006, and a graduate certification in chronic pain management from McGill University in 2015. Tanya's special interest in pain science has led her to become the pain lead for the Lifemark Atlantic region, where she continues to provide care to a wide variety of patients while mentoring and educating Lifemark clinicians on pain science and best approaches to enhancing the lives of clients with persistent pain symptoms. Take it away, Tanya. Thanks so much.
Great. Thanks, Monique. And thank you for the invite and the opportunity to speak with you today. So I'm hopefully you can see my slides there. And the title of the presentation is Life is Now, to hopefully meet the needs of this conference about moving cases forward and offering a solutions-based approach, particularly in persistent pain. So as a physiotherapist with a passion and interest in pain and complex pain, I attempt to offer or bring a sense of hope and optimism and movement optimism and reconnecting with life for folks that I work with. I often mention to patients that we think we don't get an owner's manual with our body or for our lives. However, the owner's manual often lies within ourselves, and with the right approach, we can help people to be open to this and explore a path forward, because as it says, life is now. So in terms of the objectives for the presentation today, I hope to cover my approach to assessment, particularly with complex and persistent pain, to discuss the role of therapeutic alliance and how our language matters in our communications with our patients, and how we might use this and consider the drivers to an individual's pain experience. I hope to review how pain science education is offered in an individualized and patient-centered manner in an attempt to help people make sense of their pain experience and reconceptualize their understanding of it. And this would be in line with our modern understanding of pain. I want to touch on how to apply this knowledge through movement recovery guidelines and how we can help people move forward towards the embodied experience of safety through using graded exposure within a multidisciplinary or interdisciplinary team setting. And lastly, I have a case study to share and just to share a couple of great resources. So to start, as it says, we want to begin with a comprehensive assessment, and to understand pain, we must seek to understand the person in pain. And this obviously, it certainly begins with a comprehensive assessment and in allowing the patient to tell their story and share their pain experience while we gather the full history. Giving space and time for a patient to speak without interruption is very important. Of course, as a physiotherapist, this would include a thorough musculoskeletal, neurological, and functional assessment.
No. Yeah, we already went by Barrie.
To rule out anything sinister that might be going on.
Yeah, we're in Bradford.
And gather information about an individual's impairments and capacity while keeping an ear to clues about their beliefs, about their meaning of their pain, and ultimately to arrive at a working diagnosis, which can help guide treatment. Taking the time to complete this thorough evaluation of the patient's willingness to move and finding movements that are feared and movements that are perceived as safe is key. Overall, certainly the assessment of general health, comorbidities, diet, level of physical activity can help evaluate the whole ecosystem of a person. While I often include questions about the impact of pain on an individual from a psychosocial perspective, like their connection to work or lack thereof, their family situation, their leisure activities, sleep, this helps gain an in-depth understanding of the person. Interdisciplinary collaboration with occupational therapy and psychology is certainly the gold standard. All right, so just to summarize the tenets of the comprehensive assessment when I approach someone, approach a persistent pain case. And then there are special considerations that I would include throughout the assessment, and to explore individuals' beliefs and views around their pain and what it means to the individual. So does their language and behavior suggest that pain means damage? Do they express or demonstrate fear of movement? Are there any signs or expressions that they can change or modify their pain? This is an important component in exploring any misconceptions around pain beliefs and their self-efficacy. Also, I'm looking for signs of physiological dysregulation or overprotection, and this I'm looking for these signs to show up like breath holding, bracing, body tension, guarding, and in particular how this might manifest with attempts at movement. It's important information, and individuals might be unaware that this is occurring or part of their experience. and gathering information about sympathetic arousal and the person's ability to control or change this is important, and can begin to identify opportunities for treatment, intervention, and changing their pain experience. Often in persistent pain states, folks can experience changes in the ability to sense or control the part of the body where they experience pain, or in general, and it can result from poor accuracy of signaling and response within the body. So a sense of disconnect with the painful part and a lack of motor control. So exploring and connecting individuals to feel subtle non-pain sensations in the body is often warranted. So after and during the initial assessment, we consider the role and why therapeutic alliance would matter. So based on information from the psychotherapy literature, it's been cited that specific techniques that we apply in our practice might account for approximately 15% of the total outcome, whereas almost half of the outcome is related to the therapeutic relationship and client expectation and contextual factors, whereas the remaining 40% of the outcome is totally outside of our control. So leveraging the connection and the relationship and alliance is vital in working collaboratively and building trust to ultimately support and empower behavior change. So our words matter. Language and words can impact social, psychological, biological, and cultural factors. And we can influence the meaning assigned to pain and the balance of safety and danger within the body. So Lorimer, Mosley, and Butler have been cited to say we will experience pain when our credible evidence of danger related to our body is greater than our credible evidence of safety related to our body. For example, saying is commonly done to a patient that they simply have pain because of wear and tear. This may lead to fear, worry, and danger, and to the reasonable belief that general exercise will only make things worse, so it's thus avoided. However, this is contrary to current evidence. So meaning is a powerful cognitive contributor to the need for protection and can influence the pain itself, the person's experience, and their response to pain. So why would we teach patients about pain? There has been a large number of high-quality studies that has shown that teaching people with pain about neuroscience of their pain produces some impressive and immediate long-term changes that are including that it would reduce fear, help folks reconceptualize their pain. It can actually decrease their pain. Knowledge is power, and reducing threat through offering a valid, non-threatening physiological explanation for pain has been shown to actually decrease pain. Can lead to movement and function improvements, prevention of chronicity and disability. It emphasizes patient-centered care because often these conversations are directly about the individual's experience, their beliefs. It minimizes unnecessary interventions, improves quality of life, and offers hope for change. Fosters self-efficacy and enhanced sense of control, and leads to empowerment of the patient through strategies for self-management. And of course, can promote the therapeutic alliance. So some of the target concepts that we consider in pain science education, I've broken them down here, what is commonly thought and common sense, what people might think, and then what science tells us. So this question is pain all in my head? Is that what you're telling me? And we acknowledge that pain is always real. That folks say they can't understand their pain, but research has shown us that learning about pain is the first step to recovery, and it does help. That pain means I am damaged, and that the job of pain is to tell you how bad you're damaged, but the job of pain is not that, and it doesn't equal damage. And there's lots of ways that we can share and challenge this belief. That pain is simple, and it's actually the reverse, that pain is complex. And it's about protection. The job of pain is to protect us and promote change in our behavior. That people can often think that nothing influences their pain. And what science tells us that pain is very multifactorial and often depends on context, and recognizing many of the multifactorial drivers and contributors to the pain experience can assist with change. That persistent pain means I am not healed. whereas persistent pain is about overprotection and changes in the nervous system. And exploring that on an in-depth level can be very helpful. Folks can say, I can't change my pain, but offering hope and opportunities that we can retrain the pain system, retrain the nervous system, and share concepts around neuroplasticity. So there's many different methods of how we deliver pain science education. For example, this can be done on one-on-one, in group, or virtual. I have done hundreds of virtual pain science education sessions. It can be done in groups, can be offered sort of as sound bites or nuggets, as I like to say, through treatment intervention, or more in in-depth or intensive type manner with dedicated sessions to this purpose. Sharing analogies, metaphors, and stories can be helpful. Using videos, visual infographics, written handouts, trying to tailor the treatment approach to how folks like to learn and what makes sense for them. So some sample pain science education topics or sessions that I have been delivering offer the first session to offer an introduction to pain education and pain science and the role of the nervous system in the production and perpetuation of pain, offering how pain is not an accurate measure of tissue health, that pain equals protection and persistent pain overprotects, and we can learn how to tame the beast. In the second session, I carefully explore the role of the brain and the body and the perception and the production of pain and how it can modulate the pain experience, sharing that pain is weird and the nervous system is sophisticated, using amazing pain stories to help dispel myths and reconceptualize. Using examples like the pain associated with brain freeze, that's real and kind of strange and weird, the severe pain that can happen with a paper cut, phantom limb pain, how we can have injuries without pain and pain without injury. In the third session, applying this information using movement recovery guidelines and offering strategies. Often a breathing practice and body awareness practices are introduced here. And then lastly, reviewing their knowledge and creating a plan to move forward, specifically related to goals and the individual's pain experience. This type of education is best complemented with an embodied, active, physiotherapy supported or occupational therapy supported functional approach to recovery. So what are these movement guidelines? And so when we are approaching pain, when we've had changes with the nervous system, we ask folks to move to the edge of the increased pain and there ask some questions. Am I safe? You don't want to do movements that you don't perceive are safe. So we want to find movements that create that sense. And then ask, will I regret this later? So using these words, I'm sore, but I'm safe. And then once you're there, continue at the edge of this increased pain, knowing you are safe and you will be okay later. And then there's more to do, keeping your breath calm, keeping the body and muscle calm and muscle tension low, and monitoring the pain, not ignoring it or paying too much attention to it. And so start low, go slow, and using concepts of provoke and recover. So we often have three primary goals of rehabilitation, and these include improving function, restoring quality of life, and decreasing pain to bring folks to a place of wellness. And as this picture suggests, there's many different paths to achieve this outcome, and it might look different for everyone. It might look like restoring movement, re-engaging with life, and decreasing pain, or re-engaging in life when function and pain are not going to resolve as well. A great analogy here, a perspective, is rather than focusing on decreasing the size of the pain, increase the size of the individual's life around the pain. And then lastly, restoring movement as a way to decrease pain and re-engage with life. So using this concept, as it states in this great paper by Cananero, from moving folks from fear to safety, using a graded exposure approach by identifying feared movements or activities and breaking them down into smaller steps and components. Maybe this involves using imagery or visualization to expose the body and the nervous system to this load, and that can be warranted. Working on reducing the protective responses, providing an embodied experience that that pain can change and violate expectations to offer a sense of control. It can be part of that roadmap to recovery, using goal setting and planning, pacing strategies to work on resetting the alarm system and restore tissue tolerance with a multimodal treatment approach. So I hope I have time to share a case study. I'd just like to offer this case study that describes the assessment findings of a 32-year-old woman who was involved in a rear-end motor vehicle accident approximately 2 years ago, and shared concerns around persistent neck pain and headaches. While she had returned to work part-time as a server, this was also with reduced duties, and there were concerns around limitations in normal household tasks and fear around returning to her normal gym routine. She shared that she experienced poor sleep and stress with the financial loss of her work hours. So in terms of the assessment findings, she felt that there was something sinister going on, and she was requesting an MRI. Musculoskeletal evaluation did reveal near full neck range of motion and a negative neurological exam, ruling out anything sinister. There was evidence, though, of breath holding and weakness and spasm on attempts anti-gravity neck movement, and a general lack of awareness of neck control and engaging some deep neck stabilizers. The treatment that was offered was this individual participated in 4 virtual pain science education sessions, 1 hour in length, one-on-one, and tailored to her experience. She was offered a follow-up email post each session with resources, infographic handouts. She was introduced to regular breathing practices and body awareness and to connecting with the neck, and there were graded exposure to neck and upper body exercises. At the conclusion of the education, she expressed that it would help to validate and explain her persisting symptoms, and it certainly made sense for her. Answering her question, why am I still experiencing this? She noted a reduction in feared movements, and she was no longer seeking an MRI. She was open to accepting this information, and she expressed a readiness to move forward with her active exercise program with goals to get back to the gym and gradually increase her work hours and duties. So to share some available and great resources that are out there, the session, it was titled, in the first session I often offer, Tame the Beast. This comes from Australia, the NOI group, and this is a great website full of credible information and a great video there. It often requires interpretation and support with a clinician, though. The Life is Now website offers steps around exposure to pain science education and some mindful breathing and body awareness activities. This is a new resource that's become freely accessible out of the UK. It's called a 10 Footsteps program, Living Well with Pain. And then also the online Pain Care for Life program is a very in-depth, comprehensive, available resource. Okay, I think that's the end of the presentation. And again, I apologize for the internet interruption. I hope everyone could get the good information out of the session.
Perfect. Thank you, Tanya. We do have a couple questions for you, if that's okay. Shouldn't this information be woven in on some level in the care of all injuries, really from acute to chronic?
Yeah, sure. Ideally, I think this education is not exclusive to persistent or complex pain, and I think it could, pain is pain, and offering this information and the appropriate language and sharing information about how pain, from an evidence-based modern understanding, is a product of the nervous system, and when we're seeing signs of dysregulation or concerns, that we might offer breathing approaches early on to reduce overprotection and sort of prevent chronicity or prevent a trajectory of a case moving in a direction where we don't want it to go. Typically most folks recover with a typical treatment approach, but perhaps more and more there's increased allostatic load and stress on individuals, and I think the coping mechanisms might need to be bolstered and provide a sense of resilience for folks. So giving this, through all approaches to care is ideal.
Thank you. And Did you find success using these techniques for people who have become very ingrained in the disability mindset?
Yes, it certainly is the approach that you'd want to offer for folks like this, to demonstrate that they're focusing on what they can do, not what they can't do, and if they have that sort of disability mindset or that maladaptive belief, and hopefully bringing them to a place where you can have genuine conversations and having them ask the questions: why is my pain like this, and what can I do to control it? Those are the questions that we want. The worst pain is sort of unexplained pain and unchanging pain, and that unknowable. So offering that reassurance and education can hopefully shift, and is the best available evidence to shift folks out of that mindset.
Thank you. And we have one more. As a employer or a funder or an insurer, how would we know if that's actually being addressed at the clinic level? Like, how can the insurer or the employer understand that all of the concepts that you've spoken about are actually being applied?
Yeah, that's a great question. I think you want to look for sort of evidence that the communication and the focus of treatment does involve that time spent for education, and it's not solely focused on passive treatments and treating it as purely a mechanical or a biomedical aspect, but usually embracing that biopsychosocial approach. And so looking for that there's tools being offered related to pain science education and self-management. You might receive information around concerns regarding psychosocial flags or other drivers to the pain experience that they would look to be assessed, and that might warrant more a multidisciplinary approach. So looking for those aspects that might come up in reports or communications.
Perfect. And another one snuck in, so I'm going to ask you, I think we have a couple minutes left here. Can physiotherapists order an X-ray or MRI images, and can they refer to specialists if further care or investigation is needed?
So I think that varies very much province to province. Here in Nova Scotia, there are pockets of areas where it is within scope of practice. However, it's not from the public system quite fully accepted yet to be able to do that. So there's different legislations regarding referrals for imaging. I think that it's my understanding that in parts of Canada, physiotherapists have different scopes, and some are embedded in emergency rooms that do allow to do that. And the second question, I suppose, regarding referral to specialists, the direct referral, in my understanding, I've not been able to do that here, but through the family doctor, primary care provider, nurse practitioner, I suppose, could send that information that there might be warranted referral onward, but directly that cannot be done by physio here in Nova Scotia anyway.
Perfect. Thank you so much.
Thank you.
Thank you, Tanya, very much for that. And thank you for also bearing with the technology issue. Technology is wonderful, but as we all know, sometimes things just happen that are outside of our control. So thank you for working through that and being able to provide the information to us. I think it's really an important conversation to have in any of our files in terms of how we can help reshift the language or the conversation, even when we're having these discussions with our client, when they're on the phone and so forth, because a lot of times they may have already spiraled down, and it takes a lot and quite often for them to hear that message of how do we change that mindset to focus on what can we do, our ability versus disability, and helping reinforce that message over and over and over with them and create that plan to help them move forward. I think those are things that not just clinicians can do, but even ourselves as case managers or working with the individuals on the file. So I really appreciate your insights into that. And thank you for sharing that resource as well with everyone. And I think that's a great technique for us to be able to utilize. So thanks again for your time today, Tanya. We really appreciate your insights.
Thanks.
I'd like to welcome Monique back, our Director of Business Development in Atlantic Canada, to introduce our next speaker.
Good afternoon once again. I'm very pleased to introduce our next speaker, Rebecca Satterley. Rebecca is a regional managing partner with Stuart McKelvey in Nova Scotia. She is President, Board of the Canadian Association of Counsel to Employers. She's member of the Canadian Association of Counsel to Employer, member of CACE Human Rights Committee. In 2022, she received from the Labor and Employment Law Lawyer of the Year in Halifax. Rebecca's clients find that the government regulators, such as occupational health and safety, human rights, and employment standards, continue to make day-to-day operations increasingly challenging. Through understanding the legal issues and the business of her clients, Rebecca is able to develop strategies and solutions that solve the problems they face. Her diverse client base includes large national companies, owner-managed businesses, and non-for-profits. I will leave it in your hands now, Rebecca. Thank you.
Thanks, Monique. Okay, I'm just going to get my presentation up here. All right. So welcome everyone. I've called my presentation "Accommodating Mental Health in the Workplace: Innovative Solutions," and frankly, I'm not sure if innovative is the right word, because what we're doing when we're dealing with mental health concerns in the workplace is we're taking all of our learnings over the past however many years of accommodating physical health issues and applying them to mental health issues. So I think, step one, whenever you're dealing with accommodation, is to understand what you're talking about. So what's going on and what does the employee need? And I think that we've got a couple of concepts that sometimes get intertwined, and that's mental health and mental illness. Mental health is like physical health. It's our state of well-being. Mental health includes our emotions, our feeling of connections to others. It's everybody's ability to manage life's highs and lows, and not everybody is great at that. We know that. Mental health is something different. Mental illness is something different. It's characterized by significant alterations in thinking, mood, behavior, and it has an impairment on people's ability to function. So what we're talking about here is accommodating mental illnesses. So in order to accommodate somebody's mental illness, you need to understand what it is. And that's not about diagnosis per se, because there's some limits on in the employer's ability to get a diagnosis, but it is having some brackets around, is there a mental illness involved that does constitute a disability? If yes, then what kind of accommodations is the employee looking for? And is that something that the employer can do? Not a mental illness is a disability when there's some specificity and some substance around a diagnosis. So it is not just stress itself. It is an anxiety disorder. It's a major depressive disorder. It is not something less than that. And I think it's really important because as we know, not stress is something that is experienced by everybody. There's not one person on this call who doesn't have some degree of anxiety and stress throughout their lives. So the question is, when does that arise to something that the employer needs to deal with? So a bare assertion of pain, anxiety, or depression, that's life. And that is something that people have to learn to live with. But for many people, it goes beyond that, right? And so there's this kind of quote from one of the good arbitration decisions is that I have some difficulty in finding that stress by itself is cogent evidence of a medical disability. In order to come under the important protection of human rights legislation, there needs to be a diagnosis with some specificity and substance. References to stress and other symptoms are not enough to establish a mental disability within the protection of the Human Rights Act. So for employers, they're left with a very challenging situation in a lot of occasions because mental illnesses still have stigma associated with them. That's one problem. The second problem is we have a lack of mental health care in Canada. So you've got a lot of people who no longer have access to a family doctor, definitely don't have access to complex care for mental illnesses. So you've got somebody who's presenting in a certain way, who says they've got some concerns, and they can't get the medical information to support those concerns. Or you've got people who are dealing with stress, general stress that doesn't rise to the level of disability. Or you've got part of some mental illnesses is the inability to go seek medical information and to get that information. So always when you're dealing with mental illnesses, you're dealing with a significant number of challenges associated with those diseases itself. So as employers, there's no question it's definitely a difficult situation to deal with and to figure out the accommodation process. So you've got to go back to basics, and you've got to go back to understanding to the best that of your ability what the nature of that disability looks like. So you've got to start there. You've got to understand what it is, what limitations is it or restrictions exist for your employee or for the person that you're helping, and how does that manifest in the workplace? So if you've got somebody who can't concentrate for extended periods of time, that is a restriction that an employer could look at and say, okay, how do we accommodate that? And then, as employers, the other things you're going to want to know is, okay, is this something that's going to go on forever, or is this something that's going to be for a defined period of time? And often with mental illnesses, you're dealing with something that may wax and wane over time. So you're dealing with it, not just from what's going to happen today, but it may last for a month. It may get better, it may get worse. So you're dealing with a bit of a roller coaster. You're going to want to know as an employer that the employee is getting some treatment for whatever their concern is that they're experiencing, and that there is a basis for that medical condition. So you've got that information. So then what are you going to do? What is that duty to accommodate look like? So it's not enough to just know about the mental illness itself. You've got to be able to then to put, to get some practical solutions to figure out what that is going to look like. And I am definitely finding in today's day and age, we started with dealing with family doctors who, by the nature of their practice, were sort of the ones who were dealing with most of these issues. I'm starting to see a much broader variety of healthcare professionals who are dealing with mental health issues, not necessarily diagnosing them, not necessarily dealing with the medication side of them, but actually dealing with the practical stuff as you come into the workplace. So occupational therapists, maybe social workers, obviously psychologists, but I'm starting to see a broader range of people who are dealing with mental illness and helping employers and employees figure out what that accommodation process might look like. So as an employer, if you're thinking about how do you craft this and what do I look like, you need to get that expert opinion or advice. This isn't something that you're going to easily be able to figure out on your own. You've got to be reasonable about the amount of medical information that you need. And if you're asking for medical information as an employer, you should be paying for that medical information. But most of the information that you're going to need, it's not something that's coming from our public healthcare system. And then for employees, there are responsibilities too. So it's not just about the employer, it's also about the employee. And this is where there's often just such a significant challenge when you're dealing with mental illnesses, because the illness itself can be part of the problem, part of getting that information forward. And we see that all the time. But really, the employee needs to come forward and request an accommodation. We'll come back to the duty to inquire later, but that is what you as an employee you need to be doing. You need to give medical information. Yeah, it's tough. Yeah, there's some confidential stuff associated with mental illnesses. But if you want to have the employer do something different for you or change the way in which you operate in the employment environment, then you're going to need to, as an employee, provide that information. And then you need to cooperate. And I think everybody has to realize that no accommodation is perfect, right? Because you're changing what the reality is, what other employees are being asked to do in some way, shape, or form. And so it probably is never going to be exactly what the employer wants. It's never.
Sorry, Rebecca. Unfortunately, you've been muted here quickly. If you can you just need to unmute yourself. Don't know what happened there.
I do not know what happened there.
Thank you.
Okay, so I'm just, oops, and I think I've lost my slides there somehow. Let me. Okay. Employee responsibilities. I'm going to go on. I think I probably didn't finish that, but we can catch up in some scenarios that we're going to go through and any questions at the end. So the other part of some workplaces is that unions are involved too, right? And it is, I find, when you're dealing with a unionized environment, when you're dealing with these complicated accommodation issues, that it's really important to engage the union early in the process, get them involved and get them helping with figuring out what the solutions are going to be. There may be some privacy issues, some things that, you know, you've got to work around, but I find if you've got a good relationship with that union, getting them involved early is really helpful for a couple of reasons. One, you want them to buy into whatever the solution is, particularly if it's not going to be perfect, so that they're seeing the process unfold before them. But sometimes you're looking for changes to the collective agreement. Maybe it's a seniority issue, maybe it's moving someone to a different bargaining unit. So getting that union involved early in the process is really important. And sometimes you just can't solve the problem, that there's nothing you can do to help that employee become, stay in the workplace and become an effective employee. So it's always so impossible to talk about undue hardship and what that means. And it's a high standard. It's definitely a bar that is difficult for employers to jump through or jump over. But there's some things that we can say. First of all, you don't have to hire somebody else. So if you've got somebody who can't do a job for whatever reason, you don't have to hire somebody to help them out. Hire somebody to do part of their job. If somebody can only work on a part-time basis, you don't have to pay them at full-time hours. You absolutely do not have to risk other people's safety or the safety of the individual, but you've got to be realistic there. It has to be not just a perceived risk. There has to be a real risk to health and safety. But in safety sensitive environments, this is really important and something employers and employees need to think about. You don't have to create a wholly unproductive role. So we don't have to sort of bundle tasks that are not meaningful for an organization and put them together. And then you need everybody to cooperate, right? So you need employees to be part of this process and to be part of the solution. So then how do you figure out what an accommodation should be or could be, or what should you be doing? So when you're looking at an accommodation, you're going to look at how the work is performed, what work is performed, how the work is managed. And then some of the things that you might look at are more frequent breaks, clear expectations about tasks. One of the things that I'm seeing more and more is that instructions be provided to employees in writing. In some ways it sounds really easy, but when you think about maybe in certain jobs, all the directions you might give to an employee during the day, that it is, that could be a very challenging thing for employers to do. The way that you give reinforcement or performance reviews to people, that can always be very challenging to people. Other things that employers may have to look at is changing the job duties. So is there one particular duty that an employee can't do? Can we move that and still have a productive job? Are there ways to modify a workstation to provide special assistive devices for employees? I'm seeing a lot of now employees requesting noise canceling headphones because there's a number of disorders that cause people not to be able to concentrate as much. So having that, that heads down time is really important. Using technology in certain ways, additional training for employees. Maybe it's allowing employees time off work, right? Maybe you've got somebody who can only work 3 days a week, and that is the best that they can do. Or maybe they can only work half days. Again, that doesn't mean that you're asking people to be paid full-time hours and work on a part-time schedule, but these are the things I think that employers need to think about and be cognizant that these are things that could be done. So there is definitely going to be challenges when you're going through this as an employer. You're dealing with the stigma associated with mental health accommodations. You are dealing with privacy issues with people who may not want to provide that information. My experience is you're dealing with a lack of information, a lack of medical information, and you're getting medical information that may not always be as reliable as you want it to be. And so all of those things make accommodations, I think, quite challenging. So what do you do as an employer? Um, you're trying really at the end of the day to get as much information as possible. So you're going to follow up with the employee to get that information. This includes writing a letter to the employee's physician. Now, I always give it to the employee to give to the physician, but we will often write the letter that says, here's what the employee's job is. Here's what the employee says they can't do. Here's some of the challenges we're having. You can request an IME if you're really stuck in a particular situation. And then, when you're talking about this, when you're trying to get people back into the workplace, when you're looking at accommodations, you've got to look at safety, you've got to look at continuity and consistency and implementation. So you're trying to have as less disruption in the workplace, not necessarily for the employee or for the manager, but for everybody around them, right? For the clients, for the other employees, to make sure that the business is running as efficiently as possible. So what do successful accommodations look like? What are we looking to see? Well, we're looking to see something individual. It's always every single accommodation process is different. Every single accommodation is different. So you're always looking at those individual plans for each employee that are tailored to their limitations. I think a big piece of this is educating managers and supervisors. You often get a lot of pushback, even in today's day and age, that, about dealing with people who, have specific challenges in the workplace. And the rumor mill is running rampant. And how, what are you going to say to these people, to the other employees? And managers and supervisors can get a little twisted in trying to deal with these things. And there's no question they're complicated, right? So it's about having a solid education and training program for managers and supervisors, so they're feeling confident in dealing with the situations that they have before them. And this is not just about human resources. It is about, it is about the entire organization. And it's about getting guidance from physicians and from other occupational health specialists who can help you figure out what's going to be right for employees. So I'm going to go through just a couple of case studies, and then we're going to save some time for questions at the end. And I'm happy to have as many questions as anybody has as time allows. So scenario number one, Sam has been working with their employer for 4 years, during which time they have been a solid performer, always doing their work on time, always within acceptable standards. But Sam's behavior has changed over the past 2 months. They're late for work. They're disheveled. They're not completing their work that they've been doing well previously. And coworkers are reporting that he's been lashing out over seemingly minor issues. When asked if he was okay, Sam replied that they're fine, just not getting enough sleep. So the question is, what should the employer be doing in this particular situation? And I mentioned early on in my presentation about the duty to inquire. So most times, we don't have an obligation to check in with employees other than perhaps from a human resources and from a personal perspective. But from a legal perspective, it's not our job to go out and ask employees every day if they're sick or not sick. But in this case, we've got someone who has changed at the workplace. So the question is, does this trigger, even though the employee has not come forward, should we be reaching out to Sam and saying, look, is there something going on here? Is there anything we can do? So the short answer is absolutely yes. The employer has a duty to look into a relationship between the employee's performance and a potential disability, and to ask the questions. Now, if Sam in this case doesn't want to come forward, if Sam chooses not to provide any information to the employer, there is only so much you can do as an individual to deal with that situation. So so if the employee truly does not want to cooperate, then there is no expectation that the employer accommodate the individual. But from a best practices perspective, what an employer should be doing in this particular situation is reaching out to Sam and saying, look, we've noticed that you've not been behaving the same way you've been in the past. You seem to be struggling. We're here to help you. Is there anything we can do to help? Maybe if you've got an EFAP program, you're going to refer them to EFAP, and see if there's anything they can do. And if Sam takes you up on it, then you go down through the accommodation process. And if Sam chooses not to take you up on it, then that is all you can do as an employer. You're not their parent, you're not their relative. There's only so much you can do as a business. Okay, scenario number 2. Sorry. Melanie's spouse has recently lost their job, which we understand is causing Melanie stress and affecting performance at work. Melanie's job requires high attention to detail, which has not been an issue in the past, but for the past 6 months has not met performance expectations. Melanie has explained the family issues and stress to their employer, and Melanie's employer is now trying to figure out how to respond. So the question is, what should the employer be doing in this circumstance? And this goes back to where we started with the difference between mental health and a mental illness. So does Melanie have a mental illness? Well, certainly on the face of this scenario, Melanie has personal stress in their life, which is impacting on work, which happens all the time. It happens to all of us. It does not appear, again, based on the face of this scenario, that this has risen to the level of a mental health issue. If Melanie has been a strong performer, I still think it makes sense for the employer to go to her and say, look, you're not doing what we need you to do, and you're not doing what we know you can do. So we need to understand from you, what's happening here. Do you need help from us? So the same things when we're talking about Sam. Do you need help from us, or is there something more we can do? But if this is just and I certainly don't want to minimize the situation, but if this is just a situation of personal stress, then it may be that is all that Melanie's employer can do in this particular circumstance, and it may have to go down the road of dealing with may have to go down the road of dealing with this from a performance management situation. Okay, next scenario deals with a safety issue. So Jordan works as a laborer on a construction site at a new apartment building. So construction site, always a safety sensitive environment. Jordan was diagnosed with major depressive disorder and generalized anxiety disorder a few years ago. Last week, Jordan felt depressed and entered into a restricted area of the construction site to be alone. So the rules, so let's assume that this was a confined space area. So all occupational health and safety legislation across Canada has specific rules for confined space situations, and you can't go in these situations and be alone. The rules are that anyone entering these areas has to do so with a coworker. There has to be a lookout for safety reasons. This was the first time that Jordan experienced an issue during work related to their mental illness. So this is a situation where the safety issue relates not really to the broader population at the workplace, but relates to Jordan himself. So what is an employer going to do in that situation? So if Jordan was not depressed, if there was no mental health issues, then it's safe to say that Jordan would have been disciplined. And in any number of employers across Canada, this would be a terminable offense. So in this case, if Jordan can produce medical information that says the reason that they went into this restricted area was because of the mental health issue, then I think that as an employer, absolutely you may need to consider what an accommodation might look like. But as an employer, you're also going to need to be confident that this is not going to happen again, because there's significant reasons why people are not allowed into confined space areas alone, right? It is a significant safety risk that there could be a serious workplace injury. So Jordan is going to need to develop coping mechanisms or ways to deal with his disorders that don't involve going into these areas. And I think as an employer, you're going to need to feel confident when you're doing this, if you're returning Jordan to the workplace, that you have that level of confidence that this is not going to happen again. Now, change the situation slightly. What if this were not Jordan going into a confined workspace area, but Jordan doing something that impacted a number of employees? So, operated equipment in an unsafe manner. Perhaps Jordan has a substance abuse disorder and operated that equipment in an unsafe manner. So would that change the scenario? Would that change the outlook of what happened? And I think always with these scenarios, it always depends, right? So it is, I think, going to have to be looked at on an individual basis. Jordan is going to establish, number one, that they had a mental illness. Number two, that whatever the behavior that was a cause of concern, that behavior was caused in part by that mental illness. And then the third thing that is going to have to happen is that Jordan is going to have to establish a way for the employer to be confident with safety issues, relatively confident that this is never going to happen again. So I think those are the challenges that you are going to have to deal with as an employer when you're dealing with these issues. So back to basics then. What are we doing? How are we accommodating mental health issues? What is the best way to deal with this in the workplace? And go back to basics. Understand what you're talking about. So you want to engage with the employee, you want to communicate with the employee, and you want to get as much information as you can about what the restrictions are. So you want to start there with the restrictions. That is going to require input from somebody in the medical community about what that looks like. So what is it that an employee cannot do, or cannot do as well as they could do in the past once they have their diagnosis of a mental illness? And that's the first piece, is to understand those restrictions. And then it's to work collaboratively once you have that information to figure out what the solution might be. How, if the goal of all human rights legislation is to ensure that employees are engaged in the workplace, it is always seen as the most valuable part of most people's lives, where they get a lot of their self-worth from, is going to work and being a successful employee. So what do employers need to do then, along with the employees, to change that work, to help that person become that, have that feeling of self-worth and be a productive part of the workforce? And there are just a rainbow of solutions that exist out there. Employers have to look at all of them. They have to consider all of them. So I don't think there's anything, if an employee came forward and said, something foolish, I want you to hire a person to sit with me to help me do my job, I wouldn't dismiss that as an employer out of hand. I'd go through some analysis. I would say that that's not going to be valuable for the business, right? But what about having the employee work, in another location in the building that's less busy? What about having noise canceling headphones? What about written instructions? And I think an employer, if they're going to be successful in this process and they're going to have it work out, has to come to it with an open mind and be as consider all the options out there before you start saying no. So that is my formal presentation. So I'm happy to take any questions that exist out there.
Perfect. Thank you, Rebecca. We do have a couple questions, kind of leading off of that last scenario that you had presented on. So it is our understanding that the onus is on the employee to attend work on a regular and consistent basis. And with mental health issues, that's created a bit of a gray area for employers and employees deciding if and when they cannot attend work, even if there's an accommodation in place. The question is, at what point does the employer decide that they've reached, that maximum point where we need to refer them to a different process, or at what point is the maximum where you part ways with that employee?
Yeah, and it's always tough to find where that's going to be. So let's go back to basics. So first of all, absolutely 100%. The bargain that we make with every employee is that they're gonna come to work and we're gonna pay them, right? So they have an obligation to attend at work on a regular basis. So if an employee is not attending at work on a regular basis because of a disability, that's an accommodation. Now, look, it gets really easy with certain kinds of disabilities. If you know an individual is going to be off work for a year, that can be really easy. That's much easier for an employer to deal with. But if you're dealing with someone with a mental illness who may not be able to come on a more sporadic basis, that becomes really difficult for the employer to deal with that situation. So I think the first thing that an employer is going to want to do is understand, is it reasonable? Is it reasonable for the employee not to come to work? And then we're going to need some sort of process on how that decision is made and how the employee is going to communicate it to the employer. So I would say, if the employee cannot communicate to the employer that they're going to be off work on a given day. So you've got somebody who's absent without leave, no call, no show on a regular basis. That is there's not very many employers who can accommodate that easily, particularly when you're dealing with a frontline employee that you've got to find other resources to deal with. It gets more challenging if you're in a smaller business, right? So I think you've got to find those brackets and find those boundaries with the employer. But let's just say you can accommodate it in some way, shape, or form. At some point, the employee is not going to be there on a full-time basis. You're going to miss that much time. And it may be that you need to say to the employee, look, you need to actually take a leave of absence here to see if you can kind of, wrap your arms around this and get better control over your situation. Or, at some point, you might, as an employer, be able to say that the employment relationship is frustrated. And that means that the employment relationship comes to an end because the employee cannot perform their obligations. They can't come to work. Look, this is no easy feat. I think, most employers of any substance are going to have to put up with this for a couple of years. And look, it's challenging. It's challenging for the supervisor, that frontline supervisor, to deal with. It's really challenging for the other employees. But I think, as to the best that you can, get that information and put as many, as much thought as you can into when and how the employee is going to need to be absent from work.
Perfect. Thank you. And we'll do one more. With physical illness and needing recommendations, it's a little bit easier for limitations and restrictions, bending, walking, lifting, stretching, all of those things. But other than focus and concentration, which you mentioned earlier, what are other restrictions that employers can expect to receive when dealing with mental illness matters?
Yeah, I'm starting to see a whole range of them. Like I said, a lot of stuff from occupational therapists, a lot of details. A lot of it is focus and concentration, right? So there's attendance issues, there's focus and concentration. There's I think different styles of communication with certain employees. So different illnesses. If you're dealing with someone autism spectrum disorder, for example, how you communicate with that individual effectively can be very different than how you might communicate with someone who's not on the spectrum. So I think we're really just starting to see these now, the kinds of accommodations that are out there. I've seen more in the past 6 months than I have kind of in the past 5 years, and I'm seeing them evolving. But I will say it's largely focus and concentration, because really there's not much else that an employer can do other than absenteeism, other than, taking away some of the duties and responsibilities, kind of standard stuff that you'd be used to with physical illnesses, that, that those are really the big things that you're trying to deal with when you're dealing with mental illnesses.
Perfect. Thank you so much.
Thank you very much, Rebecca. I think that's been really informative, because I think around the mental health, that's one of the complexities that are added to a lot of the files and the duty to accommodate. And I think you're right that because it's a new, we're seeing it more and more in the workplace, just coming out of COVID and so forth, that people are really trying to get their heads around what does this look like, and what types of things can we expect in terms of restrictions around concentration, memory, even starting to see more things with even an aging workforce around concentration, diminishing cognitive function, etc. And people are trying to get their handle on what are those restrictions and limitations, what can they or can't they do in their job. And I appreciate we have to try different things to see where we can find that. And at some point, when you've tried a lot of different things, I think that's when then you can look at some of these things of either referring elsewhere, or maybe it is time to look at, are we ending that employment agreement, and what does that look like, and what avenues are there to do that in an appropriate way if we can't accommodate due to undue hardship. So thank you for those case examples and for raising those issues. And I think this is going to be an ongoing discussion, and that there will be more and more questions in the future around this as people are dealing with it on a more readily basis. So thank you very much for your time today and joining us. It's always a pleasure to have you. We've had you as a speaker in the past, and we very much enjoy what you share with us. So thanks again, Rebecca, for taking time today.
Thanks for having me.
I'd just like to thank everybody today for attending our event. We can't thank you enough for your partnerships that you have with us and working with us on a day-to-day basis. We hope that this conference has been able to meet some of the requests that you've had from the past conferences through our survey, and that you've enjoyed today's topic. We will be sending out a short survey after the event, along with the link to today's conference that you can access for the next 3 months. We really appreciate if you could take the 1 to 2 minutes to complete the online survey and give us your feedback. As I mentioned earlier, we're planning our next conference in April 2024. And we really look forward to seeing you then. And we really want to customize these conferences and our speakers to the information that you're looking for right now that can help you in real time. We also just wanted to, for many of you, wish you a happy holidays, as we may not get a chance to connect before then. And thank you for enjoying the conference today. We'll be just running our slide deck again for the next few minutes. If there's other questions that you might have, feel free to pop them in the Q&A and we will try and provide responses. Have a great day, everyone.